So today we're going to talk about mucormycosis and how it comes to neuro-ophthalmology. The classic stem for mucor is a patient who has diabetes, who is in diabetic ketoacidosis. They're going to present with an optic neuropathy or an ophthalmoplegia or both. The combination of the ophthalmoplegia and the optic neuropathy is what places the lesion in the orbital apex and not in the cavernous sinus or the superior orbital fissure. So this combination of optic neuropathy, decreased vision, visual field, RAPD, swollen or normal nerve, plus ophthalmoplegia in a diabetic, but especially in DKA, is the characteristic description of mucormycosis in the orbital apex. And so the localization is orbital apex, and mucor is going to come from the sinus. So we need a CAT scan of the sinuses to see the sinus disease. You could do an MRI scan here, but CAT scan is better for the bone, for the sinuses, and the fungal hyphae are dark on T2 on the MR, so it could be misleading if you do the MRI first. So CT sinuses is normally our first. In addition, patients with mucor are often very sick, and so they might not be able to tolerate an MRI. So CT of the sinuses is our normal first initial study that we're going to be going to. And they're going to be admitted to the hospital, obviously. But before you start the antifungals, we have to confirm the diagnosis. And that means ENT is the one that's going to be seeing the patient and doing a biopsy and doing the sinonasal mucosal stripping and get a good sample. And what we're looking for, of course, are the hyphae. So the hyphae are going to be seen on the biopsy specimen, and non-septate hyphae suggests that it's mucor. Obviously, you have to wait for the full fungal evaluation, the cultures, the special stains. However, once they identify the hyphae, then infectious disease can start the antifungal therapies. And what we'd like to do is avoid having to have an exenteration of the orbit or a big destructive surgery. And so the medical therapy is where we're going to start in these cases. In the book, it says to look out for this black eschar, which represents the necrotic tissue, but that is an end-stage thing. Please don't be waiting for the black eschar. So you need to know a little bit about mucor. It presents in a very characteristic way. Although the book says diabetic and diabetic ketoacidosis, you should be thinking about mucor in any immunosuppressed patient, especially patients who are survivors of solid or organ transplant or bone marrow transplant, if they're on chronic chemotherapy or chronic steroids or chronic antibiotics, if they have renal failure. The whole spectrum of immunosuppressed people has to be considered when you're dealing with an orbital apex syndrome in an immunocompromised host. Imaging with the CT of the sinuses, admit, get ENT, get the hyphae, don't wait for the black eschar, get ID, start antifungals.